In this course you will learn basic fundamentals for treatment of the partially edentulous patient, the rationale and technique for fabricating prostheses, and other specific goals, as listed in the course syllabus. Numerous resources are available for learning this material. It is strongly recommended to obtain an authoritative text, such as McCracken's Removable Partial Dentures. Most of the items mentioned may be downloaded from the website available with the class. There are 2 written examinations, 2 laboratory practical examinations, and a laboratory project, which consists of fabricating a removable partial denture through the final try-and phase. Sequential steps for this process are listed below. Familiarization with these steps may allow you to advance yourself with less impediment and confusion. Obtain a mannequin head from the laboratory technician. Make accurate alginate impressions. Pour the impressions in Yellowstone using double pour technique. Trim and finish casts. Indexing of the maxillary cast is not required. It is advised to make 2 mandibular impressions and casts. These may be indexed if desired. Mount the maxillary on the Hano articulator using the Facebook simulation block provided by the laboratory technician. Just make sure your pin is on the black line and all knobs are tight. See diagram. The chiseled end of the pin is on the guide table.
Because there are no posterior stops, these casts cannot be hand articulated. It is necessary to make an occlusion rim for the mandibular cast. Instructions on how to do this are in the course material. Using this occlusion rim, you will then record the patient's maximal intercuspal position. The mandibular cast is then articulated and mounted with stone. It is generally useful to index these casts, as you may need to take them off the stone mounting. Again, make sure the pin is touching the black line and table.
Select a mandibular diagnostic cast, either the spare cast or the one on the mounting. The cast will be analyzed with a dental surveyor. You will then design the RPD on the form provided and draw it on the diagnostic cast. The tooth preparations needed for the simulation have already been done on the simulation mannequin, therefore you will perform a few basic tooth preparations on your dentist form. Making the RPD requires a fairly sophisticated casting. Occasionally a stock tray will not be adequate to make the necessary intraoral impression. As an optional exercise, you can use a custom tray. Instructions for this are in the course material. You may also choose to use a stock tray with either alginate or PVS, to make an impression for an RPD framework. Pour this impression in pink stone using double pour method. These casts must be indexed.
You will carefully examine the cast with the dental surveyor, to make sure the necessary tooth preparations have been performed. Then write out a laboratory work authorization for a cast metal framework. The laboratory technician will then provide you with a framework. You will fabricate a trial record base for the RPD edentulous areas with acrylic, fit it to the patient, and make an AluWax maximal intercuspal recording. Mount the definitive cast to the articulator with stone using this record. You have 4 teeth to set on this case: 19, 20, 30, and 31. Then, create the wax gingival simulation. The teeth should be correctly articulated, and the simulation should be neat, clean, and acceptable to place in the mouth of a patient. Turn this in for a grade. The criteria are found in the course material. This exercise is designed to help you when you begin troubleshooting the RPD in the clinic. Each step along the way needs a signature. The following slides give you an idea about how to approach RPD service. It is important to note that RPDs can be made in a variety of ways. Although there may be no correct way, there are certainly some things you would do differently, given a second chance. It is unfortunate that there isn't a formula to get from A to B, but diagnostic templates to assist you are found in the course material. The RPD functions in an extremely challenging environment, which undergoes change over time. It is very important that patients with RPD have regular checkups. You will be more likely to avoid problems this way.
Patients present with problems which are multifactorial. A flexible approach based on patients' understanding and acceptance of treatment cannot be overemphasized. Because there is no one accepted approach to RPD design, one has to assimilate as much information as possible, and develop the best approach for an individual patient. For instance, if given the choice to cover tooth structure with metal or not, which one to choose? And so on and so forth. These criteria will help guide your decision tree. Ultimately, the educated patient should have a prosthesis that is functional, kind to the tissue, and of an acceptable aesthetic quality. It is important to note that patient expectations can be exceptionally high. Occasionally great diplomacy and compromise are needed.
Poor diagnosis is generally recognized as the most common cause of failure. Longer-term failures are due to loss of abutments due to a combination of stress, caries, periodontal disease, or poor aesthetics from wear and tear. Sometimes one can construct an RPD design which anticipates these problems, thus expanding the serviceability of the partial. Many failures can be traced to poor design. The dentists are responsible for the design. Failure to adequately perform tooth preparation is a common cause of breakage. Other factors involve undetected structural defects and improper patient home care.
Examination of the patient is critical, and involves a thorough evaluation of all the teeth. It is never acceptable to place a partial denture when there is untreated caries, untreated periodontal disease, or an incomplete unsigned treatment plan. Occasionally, one must apply the common sense rule when making these decisions, weighing all the factors to the ultimate good of the patient.
There are relatively few absolute contraindications for an RPD. Each abutment should be carefully approached to ensure that forces are distributed equitably and good design principles are followed. Teeth that are questionable should be evaluated for periodontal, endodontic, or operative dentistry. Hopeless teeth should be removed prior to fabrication of the partial. Most RPD fall into one of two categories based on how the RPD is supported. The diagram shows these two categories, and how they differ in their treatment approach.
A basic layman understanding of the motions and mechanics of the RPD will greatly simplify the task of learning RPD. The first chapter dedicated to mechanics of RPD was noted in McCracken's 10th edition. It is advisable to review this material. We will look at this more closely in a future lecture.